Hi everyone, my name is Megan, and for my presentation I chose end-of-life care. What is end-of-life care? So I found this really interesting website, the National Institute for the Aging. Check it out if you have a chance because it provides a lot of information on end-of-life care. But they state that the end-of-life care is a term used to describe the support and medical care given during the time surrounding death. So not just once somebody is about to pass or once they do, but those days, weeks, months leading up to death. So for example, older people often live with one or more chronic illness and need a lot of care. So that could be an unspecified amount of time. How does working with this specialty population different from others? So end-of-life care, when working with that particular population, the focus is typically on some of the following, such as hospice care, palliative care, decisions being made at end-of-life, how to pay for end-of-life care, how end-of-life care might be different from people suffering with dementia, and what to do after someone dies, as well as how to manage grief. So these are some of the aspects that go along with end-of-life care, and this is how it is a little bit different. So I chose to take a look at my current job versus end-of-life. So my current job, the population is adolescent or transitional age youth who are in need of some independent living skills and permanent stable housing. So a very different population than end-of-life care. So I provide case management and life skills services, as well as transportation to some medical and educational appointments, as well as helping them look for housing. With end-of-life care, they are doing end-of-life care planning. They're looking at hospice care and making sure that the patients are as comfortable as possible in the end stages, and pain management and palliative care is an aspect as well. So you can see how the two differentiate from one another. Some of the main challenges and needs that I found while doing some research was specifically with hospice care, PCPs or primary care physicians often said that they wish that they could continue with their care with their patient, and often they kind of lose them, especially if they're getting transitioned into hospice. So that was a challenge for many of the primary care providers, and that shows us that communication amongst PCP and providers is key so that continued care can still occur. With palliative care, referring to the appropriate specialist within a certain amount of time for patients that are critically ill so that they can be receiving PC early on was one of the main challenges. So making sure that those referrals are going in as soon as possible. As a social worker working with this group, prepare to address such challenges and needs. So how would I address these challenges or these needs? With hospice care and palliative care specifically, I would make sure that signed releases are signed and put in where they need to be so that communication can stay open amongst providers. I would also check in with patients directly or with the social worker, whoever is working with the patient, as to allow the patient to see that all of the teams are working together and they're getting that continued care. Refer a patient for PC with the appropriate provider within 48 hours of a diagnosis. So that would kind of be the baseline for getting those referrals in and making sure that they're actually happening in an appropriate amount of time. Then I would follow up with the patient to see that the appointment has been made. So making sure the appointment is made and confirmed and that they have that initial appointment to start. As well as educate families on hospice care and palliative care. So it can be quite a stressful time, as we know, especially when someone finds out that they have been diagnosed with a critically or, a chronic or terminally ill disease or illness. So those families are going to need that education and someone to sit down with them and kind of walk them through it. Some resources that would be needed are financial resources. We would need to make sure that we have the appropriate amount of social workers working in the medical area or in the hospital floor that are able to work with the patients. Balance caseloads, making sure that the caseload is a healthy balance for social workers. Hosting team meetings amongst any of those providers that may come into contact with the patients so that the information is all the same and everyone is on the same board, and one provider isn't telling a patient one thing or another provider is telling a patient a different thing. Making sure releases are signed, so having access to those releases. Communication amongst providers, again, making sure everyone is on the same page, and making sure that I have the educational resources to present to families, such as pamphlets, videos, or even hosting some groups in the evenings or, during the day that families are able to attend to get more information if they desire. And then, of course, adequate trainings for hospital social workers so that they are very educated and they are up to date on all of the education that they're presenting to the families. So the families would need to have that education presented to them. So they would need knowledgeable social workers. They would, of course, need insurance to take a look at the insurance and what type of insurance they have and what providers are going to be able to cover certain things, as well as what their financial obligations are, because some of those copays can get pretty pricey. They would also need a strong medical team that communicates with one another, and they would also need transportation to and from their appointments. So as a social worker, I would distinguish myself from others working with this client or patient. So as a coordinator, I've always took pride in the way that I interact with my clients. So as a social worker, I would distinguish myself by showing attentiveness and willing to listen and making sure that my clients feel that I am listening to them, by showing empathy, by managing my time wisely so that I am able to meet with all of my clients, on a timely basis. And I am following up and I am checking in with those patients to make sure they are getting all of the services that we talked about. And then also completing the summaries and documentation so that just in case we have to refer to something specifically for a patient, that is documented and ready to go. So one of the questions I had was, is palliative care necessary in order to help make end-of-life patients live more comfortably in the final stages of life? So no, it is not mandatory. However, it is strongly suggested and beneficial for the family, and here's why. I found that patients who were referred to outpatient PC had improved end-of-life care compared with those who did not receive inpatient PC. So those that did not receive it, kind of didn't have that improved end-of-life care compared to those who did. And it is also suggested that patients who receive PC visit the hospital or ER less than those patients who did not receive PC. So yes, it is very beneficial to the families, although not necessary. The second question I had was, do you think patients with PC are more likely to be able to manage their end-of-life symptoms better than those who do not? And here's what I found. Yes, there were less hospital visits. However, there's no definitive answer because every case is different, right? So patients who do not acknowledge the full benefits, so patients who do not want to take advantage of the services that are available or do not attend all of the appointments or all of the care appointments, that may not be very beneficial, as well as cultural views. So cultural views are a big part of this because not every culture is the same, and there are many different cultures out there, and some of them may not agree with end-of-life care. So it's a case-by-case basis, and of course, insurance and finances are a big piece of the puzzle. So providing that they have all of these things in place, yes, I feel like the patients with PC are more likely to be able to manage their symptoms better than those who do not. But of course, we have to factor in environment and demographics as well. So I found that, during this study in 2001, I thought this was interesting. 42 million Americans lacked health insurance coverage, and absence of health insurance is correlated with lack of access to medical care generally and poor health outcomes. So although this is a little bit older, I know that Obamacare was the hot topic, and insurance is still a hot topic today. Pharmacies in neighborhoods where the majority of residents are non-white are less likely to carry opioids than pharmacies in predominantly white neighborhoods. So that I thought was something very interesting because it makes sense to me why that, some people in a poorer demographic may not be able to access some of the medical resources that are available to them. So, I really think that people with PC or patients with PC are able to manage their health a little bit better. So one day, hopefully, there will be more access to services in those types of neighborhoods and environments. But until then, that is the end of my presentation, and thank you all for watching.